Neonatal jaundice is a common condition in newborn babies, and today on Health with Patricia, we want to understand it all because it's characterized by the yellowing of the skin and the eyes. My name is Patricia Roxanne Hammond, and my guest today is Dr. Edward Akosa Danso. He is a general practitioner at the police hospital. I keep missing your name, Dr. Edward Akosa Danso. Yes, I got it right. He is a medical doctor, or let's say a general practitioner at the police hospital, and he's going to help us understand what neonatal jaundice is. There is this thing that people do normally. Before then, welcome to the show.
Thank you very much.
There's this thing that people normally do. This is a traditional method where when the baby is born and you're discharged to the house, you let the child meet the rising of the sun. I heard that sun contains vitamin D and it helps clear jaundice. How true is that?
Well, in order to deal with that, we have to understand what is actually going on. Neonatal jaundice, like you rightly said, it's two words, neonatal and jaundice.
Okay.
When we talk about the neonatal period, it's the first month of life. Mm-hmm. So from birth till the baby is 1 month old.
Okay.
Then jaundice is the yellowish discoloration of the skin and the eyes. So yellowish discoloration of the skin and the eyes in a newborn who is not up to 1 month old.
Okay.
And it's caused by something called bilirubin. So bilirubin is gotten from breakdown of red blood cells. So in the newborn, they have red blood cells that are not as strong as ours. And when they are broken down, the bilirubin forms.
Okay.
Bilirubin in itself, it doesn't really cause much harm. But in the newborn, what protects their brain, something called the blood-brain barrier,
okay,
is not totally formed yet. So when the bilirubin crosses that thing, it can affect the brain, and it's neurotoxic to the brain, can cause delayed speech, developmental delays, and even death.
Okay.
So if this happens, we need to let the bilirubin go down.
Okay.
When you take it, it's assumed that when you expose the child to the rising sun, it can convert the bilirubin and make it better. The jury is still out on that, because if the jaundice is from a problem, then that wouldn't work.
Okay.
But if the jaundice is normal, so there's something called physiological jaundice and pathological jaundice.
Okay.
But usually it's very difficult to tell by the look of it. So if it's physiological jaundice, yes, it might work a bit. But you being the parent might not know whether it's physiological or pathological.
Yeah.
So it's always advised to go to the hospital
okay,
and get a doctor.
With the age, is it so with preterm, irrespective of the term that the baby came in, the baby is at high risk of jaundice, or when the baby is full term? Like, I want to understand.
Okay.
Is it because from my research, it's mostly categorized in the preterm okay, babies. Yeah.
So let me talk a bit about obstetric and gynecology.
Okay.
When you talk about a term baby, it's common knowledge that women carry pregnancy for 9 months.
Yeah.
But in the medical fraternity, we divide it into weeks. So if you give birth before 37 weeks, then it's called, the baby is a preterm baby.
Okay.
But any baby born after 37 weeks is a term baby.
Okay. Okay.
So now we have to understand how the jaundice comes about. Like I said, the red blood cells are broken down mm-hmm, to form the bilirubin. In everybody, in you and I, we have what breaks down the bilirubin, what converts the bilirubin to things that we can excrete, either through our feces or our urine.
Okay.
In the newborn, that system is not fully developed.
Okay.
So that's why the newborns are at risk of neonatal jaundice. And the reason why the preterms are at a higher risk is because the newborns have, let's say, an adult has maybe like 100% function. A term baby will have maybe 50% function. But then a preterm will have about 30% function.
Oh, okay.
So preterms are at a higher risk.
Higher risks of neonatal jaundice.
Yes, and epidemiologically, 8 out of 10 preterm children or babies will have neonatal jaundice. whereas 6 out of 10 newborn babies will have neonatal jaundice.
Okay. So how is this treated?
So the treatment...
Okay, so before then, how do you diagnose it and treat it?
Okay. Diagnosis in our medical field of work, diagnosis is stepwise.
Okay.
A history, examination, laboratory investigations.
Okay.
So with the history and the examination, usually we do that together. Neonatal jaundice is something you can easily pick up.
Okay.
The trained eye can easily pick up. And even women are trained to pick it up because they come into contact with the babies before bringing them to the hospital. So you'd see it on the eyes, on the skin. When you blanch the skin, when you look at the sclera, that's the white of the eye, you see it become a bit yellow.
Okay.
So then you have it at the back of your mind that this baby might have neonatal jaundice.
Okay.
Then you follow up with a lab called a serum bilirubin level.
Okay, so in this case, I want us to start from the baby has just been delivered.
Okay.
Because when I had my baby, immediately they took her to the NICU. And the next thing I saw was she was under the blue lights. I want to understand, what do you look out for just after taking the baby, either through CS or normal vaginal birth? What do you look out for before putting the baby under the blue light?
So every baby that's born in a health facility is examined.
Okay.
A full neonatal examination. We examine the heart, we examine the respiratory system, we examine the nervous system. Then we look at the baby, we look in the eyes, we blanch the skin, like I'm saying.
Okay.
So at birth, you can actually pick up neonatal jaundice by blanching the skin.
Okay.
And if the level of bilirubin is very high, you would even see it on the skin without blanching it. So you see the skin with a yellowish discoloration.
Just after you take the baby out of the woman, you clean it, you see that it's yellow.
So we call that jaundice at birth. And jaundice at birth is what we call a red flag. It's usually pathological and has to be managed immediately. So jaundice at birth, so if you have jaundice at birth, it's usually pathological, has to be managed immediately.
Okay.
And we usually have to find out the cause of it. Sometimes it's from blood group differences between the mother and the baby, especially if the mother has a negative blood group and the baby has a positive blood group. I don't know what your blood group is.
I was B positive. I'm B positive and my baby is B positive.
Yeah, so then that's not the reason for your baby having jaundice. It could be the other causes like enzyme deficiency, something called glucose-6-phosphate dehydrogenase. It's an enzyme that helps red blood cells to withstand a lot of stress.
Okay.
So if that enzyme is deficient, the red blood cells tend to break down.
Okay.
Then you have a lot of bilirubin accumulating.
Okay.
There are other rare causes that I wouldn't want to go into.
No problem.
But then once you pick up the jaundice, you have to treat it with the blue light.
Okay.
Yes. And the reason why you have to treat it with the blue light is what I explained earlier, the complications. There's a term called kernicterus.
Kernicterus.
Yes, it's a constellation of symptoms that's associated with bilirubin entering the brain. And because it's very preventable, we do our possible best to start treatment as soon as possible to prevent that complication.
Okay. Because of time, I want us to wrap up quickly. How long are the babies supposed to stay under the blue light? Okay.
So that actually depends on how
the baby recovers.
Exactly.
Okay.
So if your baby, I see your baby now, I have a suspicion that the baby is jaundice, then I'll take my labs, a serum bilirubin level.
Okay.
Then the value I get, we have a graph called a phototherapy graph. So you plot that value on the graph. If I plot on the graph and the value is above phototherapy level, then we start phototherapy. So we start phototherapy for 1 day. The next day I'll take the sample again.
Okay.
I'll plot it on the graph. Is it still above phototherapy level? If it is, we'll continue. If not, then if it's below phototherapy level, we'll stop the photo.
Okay.
Once we stop the phototherapy, we have to monitor for rebound jaundice.
Okay.
That's stopping the treatment and the jaundice comes back. So usually when we stop the phototherapy, between 6 to 12 hours after that, we check the serum bilirubin levels again. If it's truly below phototherapy level, then you are getting ready to be discharged out of the hospital.
Okay.
If the jaundice was your only problem.
The phototherapy, whatever it is it a phototherapy light?
Yes.
Yeah. Do you increase it and decrease it, or is it at a particular level?
Usually at a particular level, at a particular distance, because it's the light that converts the bilirubin into a less toxic form. It has to be a certain distance from the baby, a certain intensity, and a certain wavelength. You realize that most phototherapy is blue, because we realize that the wavelength of light in the blue spectrum that converts the bilirubin from the poisonous aspect to the less poisonous aspect that can be excreted easily.
Okay.
Yes.
So why do you cover the baby's eyes?
And the gonads too. So we cover the eyes and the gonads.
Yeah.
Because we don't want to expose the eyes to a lot of light.
Okay.
And the gonads to a lot of light.
Okay.
Because the baby's receptors, that's the nervous receptors in the eyes, are very sensitive to light. It can cause a lot of things. Neovascularization, one. So we cover the eyes. Although the yellowing is on the eyes, it's also on the skin.
Yeah.
And the light can penetrate the skin to convert the bilirubin.
Yeah.
We also cover the gonads because the light can affect the gonads.
Okay.
When I say gonads, I mean whether
the genitals.
The genital area. Yes. So that's why we cover it.
Is it possible that after the child has been discharged, the baby can still get a jaundice rebound?
Adults get jaundice.
Okay.
Yeah. So the baby can't get jaundice again. But we are usually scared, like I said, what protects the baby's brain forms maybe within the first week or the first 2 weeks.
Okay.
So if we pick up jaundice within the first week or the first 2 weeks, then we are aggressive.
Okay.
Because we don't want kernicterus to happen.
Okay.
But if it's after the first 2 weeks, then we are not worried about the brain. Phototherapy doesn't play much of a role. Then we are looking at the jaundice from any other cause. Okay. Maybe a prolonged infection, a liver disease, or something that we have to investigate.
Okay, and treat immediately.
Yes, and treat immediately.
Finally, I had a friend. Okay, let's say there are some people, the babies do not have jaundice, or let's say they are part of the lesser percentage of babies without jaundice. But the mother breastfeeds the child, and the child ends up with jaundice.
Okay.
So in that case, is it the mother who has the jaundice, and rather introducing it to the baby through breast milk?
Okay. So that's also another cause of neonatal jaundice. It's quite unfortunate our time is limited. Yeah. We could have gone to town with the various causes of it. But a very counterintuitive cause of jaundice is breast milk jaundice. So breast milk jaundice, as the name implies, is breast milk causing jaundice. So it's not the mother that has the jaundice, and it's not the breast milk that has the jaundice. There's an enzyme in the breast milk that usually, like I mentioned, the bilirubin has to be excreted out of the body. Yeah. But the enzyme in the breast milk, it meets the bilirubin in the gut, reconverts it into a form that is reabsorbed into the blood.
Oh, okay.
Yes. So basically that's what happens. So the enzyme in the milk meets the bilirubin that was supposed to be excreted out of the body, reconverts it into one that is reabsorbed into the blood, and it gives the baby jaundice.
So in this case, even though we know how jaundice is treated, what happens to the mother? Are you supposed to stop breastfeeding?
It depends on the level of the bilirubin and when you pick it up.
Do you test the mother?
So you don't test the mother because it's not the mother that's giving the baby jaundice. And I have to mention that breast milk jaundice is a diagnosis of exclusion.
Okay.
When I say a diagnosis of exclusion, I mean the baby has jaundice. You have tested everything you can. You've checked the liver, you've checked the blood group, you've checked the enzymes, you've checked other rare causes of jaundice. But then you can't really pinpoint what is causing the jaundice. And you suspect that it's the breast milk that's causing the jaundice. Then you can test your hypothesis by letting the mother stop breastfeeding for 24 hours, then supplementing the feed. Okay. If the jaundice resolves or gets better, then you have your diagnosis of breast milk jaundice.
Okay.
So now, if you are very confident as a doctor, very confident that this is breast milk jaundice, there's no other cause, the liver is fine, everything is fine, and the level of the bilirubin, you test the level of the bilirubin, and it's not high. It's not in the phototherapy level. It's elevated compared to another child, but not in the phototherapy level.
Okay.
And it's not in the first 1 to 2 weeks of life. You can let the woman breastfeed.
Okay.
Then continuously monitor
Okay.
the bilirubin levels.
Okay.
Usually after about 3 months, or that's 12 weeks, it resolves on its own.
Okay.
Yeah.
Thank you very much, Dr. Danso. And my
welcome.
guest has been Dr. Edward Danso. He is a general practitioner at the police hospital. The show has been Health with Patricia, with me, Patricia Roxanne Hammond. At the same time next week, please continue subscribing, sharing, and liking, and finally commenting on the show. Stay blessed.